Time-restricted eating for type 2 diabetes, therapeutic potential and cautions. The management of type 2 diabetes demands interventions that address the fundamental pathophysiology of insulin resistance and beta cell dysfunction while remaining sustainable in real-world contexts. Time-restricted eating has emerged as a candidate strategy, with mechanistic rationale suggesting possible benefits for glycemic control and diabetes-related complications. However, the intersection of metabolic manipulation through meal timing and pharmacological diabetes management creates a complex clinical scenario requiring evidence-based evaluation rather than enthusiastic adoption based on preliminary data. The theoretical appeal centers on insulin sensitivity optimization through circadian alignment. Some studies in individuals with pre-diabetes or type 2 diabetes show improvements in fasting glucose, hemoglobin A1C, and insulin sensitivity following time-restricted eating interventions. These improvements generally occur in conjunction with weight loss, raising questions about whether timing effects operate independently or primarily through energy balance. The magnitude of glycemic improvements varies considerably across studies, with some showing clinically meaningful reductions in A1C while others document only modest changes. This heterogeneity likely reflects differences in baseline glycemic control, medication regimens, and the degree of caloric restriction achieved. Medication management represents the most critical practical consideration. Many individuals with type 2 diabetes take glucose-lowering medications, including insulin and sulfonylureas, that increase hypoglycemia risk during fasting periods. Implementing time-restricted eating without adjusting these medications could precipitate dangerous glucose nadirs, particularly if extended fasting periods coincide with medication action peaks. This risk necessitates close medical supervision and often medication dose reduction or timing adjustments when initiating time restriction. Healthcare providers must balance the potential benefits of improved glycemic control against the immediate risks of medication-induced hypoglycemia. The impact on different classes of diabetes medications varies. Metformin, often prescribed as first-line therapy, carries minimal hypoglycemia risk and may be continued unchanged during time-restricted eating. However, its gastrointestinal side effects might worsen if large doses are concentrated during shortened eating windows. Insulin and insulin secretagogues require dose titration based on blood glucose monitoring, with conservative reductions often necessary initially. Newer agents like GLP-1 receptor agonists may actually complement time-restricted eating through appetite suppression effects, though the combined impact on eating patterns and total intake requires monitoring. Beyond glucose control, cardiovascular outcomes matter tremendously in diabetes management, as cardiovascular disease represents the primary cause of mortality in this population. The limited long-term data on time-restricted eating's cardiovascular effects in diabetic populations leaves critical questions unanswered. Some surrogate markers suggest potential benefits, improvements in blood pressure, lipids, and inflammatory markers, but these intermediate endpoints don't substitute for hard outcome data on myocardial infarction, stroke, or mortality. The conservative interpretation suggests that time-restricted eating might contribute to multifactorial cardiovascular risk reduction, but shouldn't displace proven interventions. Practical adherence challenges may prove particularly acute in diabetes populations. The disease already demands substantial self-management burden around medication timing, glucose monitoring, foot care, and dietary composition. Adding temporal eating restrictions increases complexity and may overwhelm some individuals' self-management capacity. The psychological burden of managing both diabetes and time restriction could paradoxically worsen glycemic control if stress and decision fatigue lead to poor medication adherence or dietary choices. For healthcare providers considering time-restricted eating for patients with type 2 diabetes, a cautious, individualized approach appears warranted. Appropriate candidates likely include those with good baseline self-management skills, willingness to increase glucose monitoring temporarily, and diabetes controlled primarily through lifestyle or medications with low hypoglycemia risk. Close initial supervision, clear protocols for medication adjustment, and realistic expectations about glycemic improvements remain essential. Time-restricted eating may serve as a useful adjunct within comprehensive diabetes management for selected patients, but cannot substitute for proven cornerstone therapies including metformin, lifestyle modification, and cardiovascular risk reduction strategies.